When it comes to endodontic diagnostics, this is what we have learned in the dental school. PD, pulp diagnosis. And with it came the electric pulp test, 1922. And for decades, the electric pulp test dominated the endodontic diagnosis scene. New technology after new technology. We also had the heat pulp test, running rubber wheels, melted gutta percha, electric sources. The cold test, starting with ice, going to ethyl chloride, to CO2 ice, and from there till today. In spite of the research on these questionable technologies and diagnostic methods, we still have, even in 2024, somebody trying to put it all together into what's known as the PSTT, in which they have all of these questionable technologies and methods into one presentation. Then we had the bite test, another questionable test when it comes to endodontic diagnostics. The percussion test, we learned it to be performed automatically, even without need for it. So there's a lot of questions about these diagnostic methodologies. The radiograph, one of our most important and critical diagnostic tools, even that has its own limitations. All of that is presented under the umbrella of what's known as the tentative diagnostics. Hello, I am Marwan Aboras, and my presentation today is going to focus on the story and the powers of the 4R operational diagnosis protocol, which I am so proud to present to you now. The 4R operational diagnosis protocol, 4 ROD, is the protocol for definitive diagnostics. So let's take a case. Here's a patient came to us absolutely during routine examination, and we observed these areas where you have gingival recession. This area was actually not soft when explored with the DG16 Explorer. We take a radiograph and everything is fine. We see the lamina dura, we see the periodontal ligament, the bone. There is no periapical pathology, but there is this halo over here. The 4R operational diagnosis protocol has powers, has advantages, and in this presentation, I'm going to try to summarize all of them. So here we go. My philosophy is operationalism. I advise the patient to remove the bridge, which was almost 25 years old. It served the patient very well, and thanks to the clinician who did it. So we open and we see this, caries. We clean the caries, we remove the old restorations, glass armor cement, and this is what we find. The caries has penetrated underneath, and you see this discoloration. We cleaned everything. This is coronal clean out, and we always take an x-ray. We are about to have a pulp exposure. So this diagnostic method is preventive. Yes, you sacrifice some restorations, but you save the teeth. Another patient, in which we observe again a recession and changes into the gingival texture. and again a halo, another halo, and an old root canal. I consider these recessions, these findings, warning signs. Warning signs, clinical or radiographic. They need to be investigated. And that is our role as a diagnostician. The power of operationalism again. We remove. We had no idea these things exist. Pins and screws underneath the crown and caries and breaking down tooth structure. We remove all of that, and that's what we get. This is the diagnosis that the 4ROD presents you. A definitive scene, a definitive findings, which you could make your decisions, not tentative. Another example of the power of operationalism, this patient was actually referred to me for surgery because of this pathology that we have here. That's not my philosophy. And not even completion. Within 5 to 10 minutes, you could get a lot of diagnosis and a lot of decision making and accurate diagnostics. We just cut the buckle of the crown and came off with the buildup and the pins. And all of that, you see here a crack between these different structures. The 4ROD revealed the hidden cracks and perforations. Another example, a class 1 alloy, which carries underneath. That's all we paid attention for. The patient has symptoms. But did we know about this incredible finding? So now you could talk about tentative diagnosis and definitive diagnosis. And that is the power of the 4ROD. Even in surgical endodontics, to reflect a flap is a 4R operational diagnosis protocol. And you can see it here whether coronal or radicular. We see the cracks. So the issue here is operationalism. And with operationalism comes the power of open and see. One of the greatest elements, which I will focus on and overview, that in the 4ROD we have a lot of advantages. You have a lot of new things that you did not know or even learned in the dental school. One of the things which I'm very proud about is what's known as the PPPQ, the Patient Pain Profile Questionnaire. And in the master class, each one of these powers, each one of these advantages, they're going to be having 10 to 15 to 30-minute presentation focusing on each one of them. But in this presentation, I'm doing an overview. So the PPPQ, this is what it offers you. It offers you 55 verbal descriptors, which we will discuss in a separate presentation. But the beauty is, in one document, in one questionnaire, in one form, you can get the patient dental history, yellow. And if it's green, it's reversible. And if it's orange, it could go to red. And if it's blue, it is not endodontics. So in this presentation, you have the overview of one of the second power. First, the power of operationalism, open and see, and then the power of the PPQ. Here it is. Each one of those gives you an advantage. 16 questions for patient pain history, 8 questions or 8 verbal descriptors. When the patient checks in these boxes, you know you have a case that you don't have to do a root canal. You have to investigate it. It could be reversible pulpitis, it could be occlusal trauma, it could be dentinal hypersensitivity. 8 questions that could go to endo. Or they could be actually the beginning of what I call initial apical periodontitis. 13 questions, the too late, the red zone. In the red zone, you have the endoperio problems. You have the endodontic treatment failure problems. You have the AP flare-ups. And then in the blue zone, you have the trigeminal neuralgia problems, the TMJ problems. It's non-dental. So this is what I call it, a powerful tool for orofacial pain diagnosis, not endo, not resto, not perio diagnosis of pain, but it is orofacial pain, and that will help you. This tool help you localize it. So in the presentation, you have so many advantages. I'm not going to read them, but they are for you for record. And we go into the power of 10 AD, 10 areas of diagnostic interest. In this presentation, you will have 10 landmarks in the periapical radiographs in which provide you with a system for interpreting x-rays, going from the crown down to the apex, up again to the alveolar bone and adjacent teeth. Once you use this protocol, you will have a mental image of the 10 ADI. So every time you look at a radiograph, a periapical radiograph, or a bite-wing radiograph, you will be able to pinpoint exactly what is the radiographic diagnostic finding. And that is very significant in the protocol. The protocol uses in the 10 ADI the periapical radiograph, PAR, and the bite wing, the periapical radiograph for endodontic troubles, and the bite wing for periodontal troubles and restorative troubles. These two radiographs, intraoral, been with us, and I feel so strongly about every general practitioner must believe in these two radiographs as the initial diagnostic tools, not the OPG, not the CBCT. That comes later if we need it. But in my opinion, this is a philosophy that I like to share with you. I have a passion that I like to share with you, that the periapical radiograph in endodontics and the bite-wing radiograph in periodontics provided the foundation, the diagnostic imaging tool that we built those two specialties on. That is very powerful. So despite of the introduction of the CBCT and all the other technologies, the periapical radiograph remains the backbone of diagnostic imaging in dentistry. They are readily available, accurate, and affordable. And that's what the 4R Operational Diagnosis 10AD is built on. And there will be a presentation about the scientific basis of every word I say. Here she is, Brynolf, 1967. In 1967, how many years ago, this radiologist from Sweden showed that the periapical radiograph actually and accurately depict the advanced stages of apical periodontitis. Back in 1967, in endodontically treated and in not treated teeth. And when is that? At the late stages. Not very good in the early stages. But then she recommended 2 radiographs exposed at different angles will be better. Based on this, based on her research, phenomenal research, a classic research, she showed that the most 2 important organs is the lamina dura and the periodontal space. And they are the first to go, first to be destroyed, even with endodontic pathology from inside out or periodontal pathology from outside in. And based on that, I made the 10 ADI and the presentation in the master class to go with it. Another power of the 4ROD is the power of multidisciplinary diagnosis. And what do we mean by that? It's what we learned. The endodontium and the periodontium, and between them the dentin. There is a powerful biologic and clinical relationship between the pulp and the periodontium, with all their components. And the protocol respects that. And this is why in R3, response testing, I focus more on periodontal testing, periodontal examination, periodontal assessment, more than pulpal assessment. Because perio is the foundation. And that's what I basically, when you talk, what is Abu Ras all about when it comes to diagnosis? Abu Ras doesn't believe in EPT or cold test alone or heat test and all these things we learned in the dental schools. Abu Ras believe in diagnostic biology. Diagnostic endodontic biology, diagnostic periodontal biology, diagnostic occlusion biology. But when it comes to the 4ROD, we found that the alveolar bone gives blood vessels to the pulp and the PDL. And therefore, we must respect that relationship between these two. And from there, we could see now the intimate relationship between endo and perio in diagnosis, in symptomatology, in healing, and in prognosis. So I have simplified in the 4R operational diagnosis. You do not see electric pulp test, you do not see here heat test, you don't see drill test, cavity test. What do you see? You see extreme cold test, standard of care, CBT. You see diagnostic pulp biology. You see heavy emphasis on periodontal manifestation, whether it is the isolated periodontal pocket or the fistula or the sinus. So Abu Ras' philosophy is not his philosophy only. It's based on 50 years of teaching and literature reviews and practice. So if we come here to this systematic 2018, what does it say? Well, this is the diagnostic accuracy of 5 dental tests, a systematic review, and a meta-analysis. They say the heat test is the least accurate. The electric pulp test, low accuracy. And the CBT, extreme cold test, high diagnostic accuracy. And of course, the LDF and PO, these are research tools. But when we talk to clinical, This is where we are. And based on that, these are techniques. And as dental practitioner, we must think, number one, biology and evidence-based information. So here's the cold test. We developed from ice and ethyl chloride 0 temperature to minus 26, minus 50, and my favorite was, or is, the CO2, carbon dioxide. So we go through gingival changes, periodontal, and as I stated earlier, I don't believe in the percussion test to be performed routinely on every patient. I perform it only when the patient has symptoms. Again, the research indicated percussion test is not an endodontic test, it's a periodontal test. And the bite test is good only for one thing, split vertical fractures. No cracks, cannot diagnose them. And then came to R4. R4 is the radiographic, is the restorative assessment of tooth structure and restorations. And the protocol, again, power, that I use criteria from the FDI, the Federation Dentale International, in which they issued evidence-based guidelines in 2010 and then revised it in 2023. And they basically gave us evidence-based guidelines to evaluate the restorations, aesthetic criteria, functional criteria, biologic criteria. In addition to that, when we come to tooth structure, we also evaluate it for orthodontic problems, anomalies, erosion, color changes, and tooth cracks. Very comprehensive assessment. And therefore, all of that together, I put into a protocol. A protocol is a very powerful instrument in medicine for the diagnosis and the treatment. Protocols must have guidelines, and I have fulfilled all these guidelines. And the protocol power that it's evidence-based. It's not Aboura's opinion only. Aboura used the literature, used biological principles, and put it together into teachable, learnable modality. Protocols you must follow R1, R2, R3, R4. Not R1, R4. It must be followed in sequence because it was designed according to the literature and the clinical requirements. Protocols provide uniformity, standardization, especially when you have large dental clinics. You have 20 doctors coming from different locations. Each one has a different background, and you need to have them think according to what the patient needs, not what they learned, to what this patient needs. It provides clear communication between clinicians. The use of protocols, especially in diagnosis, the 4ROD, reduces errors, error reduction. And of course, the greatest advantage is the system. Systems have power again. And all of that is done for one purpose: patient-centered care. We respect the patient wants and desires, and we try to meet them. We improve the rapport between the patient and the clinician. A patient-centered care needs people to collaborate, clinicians to collaborate, and we need to give the patient feedback on diagnosis, feedback on findings, feedback on treatment complications, and feedback on treatment outcome. So let me now, you could say, okay, how did it start? It started back throughout the years, and it evolved from Pittsburgh to USC to Prince Sultan Military Hospital or Military City when I came to Saudi Arabia, and then now in my academy. It all started back in 1982 when I was asked to edit a whole issue of the Alpha Omega journals. As an introduction to that, I wrote, "The diagnostic problem. Most in-depth endodontic diagnosis is made when pain occurs or symptoms develop at best. The diagnosis is based on observing the patient reaction to a piece of ice, a piece of melted rubber. The complexity of human response to disease and injury easily show the inadequacy of these methods. Current testing methods and attitude towards the dental pulp are simplistic, casual, and fraught with myth and fallacies." I said that back in 1982. And that was the beginning. In this issue, I introduced the beginning, the start of the 4ROD. So then we move years later. The Swedish Council on Health Technology Assessment, SBU, in June 2012, did a systematic study on the methods and diagnosis in endodontics. They reviewed like 2,000 articles in Endo. And it's a panel of the best and most authoritative, most respected endodontists, restorative dentists in Sweden and Scandinavia. And they concluded that this systematic overview discloses extensive shortcomings in the scientific basis underlying methods of applied to endodontic diagnosis and treatment. And they recommended that we should have guidelines to support endodontic diagnosis. That was in 2012. A whole document is available. So you can see now in 1982, we almost had the same conclusion, same observation. Truth always surfaces to the top, and people find it. We were fortunate to be in the United States, and we found it at that time. And more fortunate that we had somebody to support that philosophy. So what is the 4ROD? The 4ROD is a clinical diagnostic system developed by myself, and this protocol focuses on systematically and physically gathering and analyzing the health status of the structure of the periodontium and endodontium through 4 P's. The patient report, R1, the patient radiographs findings, R2, the patient response to perio and endo testing, R3, and the patient findings in terms of restoration and tooth structure assessment. The findings from all these steps are then integrated into a definitive diagnosis and treatment plan. And here she is. It goes up, R1, R2, R3, R4 to a definitive diagnosis. And each step, it has goals and objectives and procedures. In R1, you focus on the importance of meeting the patient for the first time. You want to build a relationship, you build a rapport, you collect important histories, social, medical, dental, review it all, and decide what you're going to be doing next. In that, you have the patient complaint, the histories. In R2, you do the 10 ADI, and you decide what test you're going to use. In R3, you perform the endo and perio test and any additional testing you may come up with. But now you're having more an idea of what this patient has. And in R4 is the definitive. You get yourself good infection control environment, and you do the restorative assessment using the FDI guidelines. You do the coronal cleanout, that's the operationalism. You examine the tooth for wear, cracks, discoloration, all of that. You take a new radiographs, and now you have a very good idea what this patient has. You have reports from every step, and then you make a decision. The decision you make is integrating those 4 steps together, and now you present it to the patient on one-on-one discussion and feedback. You decide what this patient problems are. If it's comprehensive care, it's an emergency care, it's limited dental treatment, is it one tooth, is it a quadrant, it's a full mouth. And you decide, is it endo, perio, prosto, or ortho? All of that now is put together, and then you go to the treatment finalization protocol, which is basically another protocol I have. There will be a master class on it, on how to proceed step by step. And that is called the endodontic treatment finalization. And my advice to you before I end this presentation, that if the first patient encounter or appointment time was insufficient, or for any other reason, the protocol implementation, you could not do you did R1, R2, and you did not do R3 and R4. Please, always try to assist the patient by resolving the complaint why they came to you for. And here are some options. These actions, these practices, improve the relationship of the first time. Removing plaque and stain from anterior teeth, no charge. Resealing a dislodged restoration, cemented back. Smoothing a sharp edge, which cutting the patient tongue because of fractured restoration or a tooth. Give them medication, sedative, or antibiotics. Explain, assure, build relationship, and reschedule for either completion of the protocol diagnostics or initiation treatment. I thank you so much for listening, and your feedback helps us improve and deliver the best educational experience. Thank you for your attention.